Please give a big round of applause for Dr. Wang.
Good morning. It's an honor to be invited here. Let me go started. So, very quick remark. We always been taught this is a very rare tumor, and because the incidence been reported about 7 per 100,000 population. The good news is, as a group of doctors interested in this disease work together, we can keep patients with neuroendocrine tumor for a long time. So the prevalence of the disease means the patient in the population live with the disease is increasing and going up very quickly every year. And you can see the statistic. So this is a picture I took in 2014. All the people come to visit me in New Orleans. I have them put a dot, say where they're coming from. So don't feel you are so special. You're not that special. This is everywhere. So the traditional approach in treating this disease, because the disease grows so slow, so people's attitude is say, let's wait and see. And I was attending a meeting, an ESCO meeting, one of the surgeons asked, the people asked that question, say, if you have a patient with a well-differentiated neuroendocrine tumor, a non-primary, doing well, what do? The panel recommendation was say, we will just watch the patient carefully. One patient started having a problem, then we will treat up. And I cannot hold my breath back. I stood up and said, wait a second, let me rephrase what you just said. You are telling me if you see a live cigarette butt in your living room sofa, you will say, the heck of it, I'm going to watch my football game, more important. And I'm going to call 911 when the TV screen becomes fuzzy because the smoke is all over the house. And say, oh, this time call 911. I said, just waiting and see approach just stupid. So the first data come out really teach us to be aggressive is from Swedish study. The Swedish surgeon look at how you treat the disease. Number one group, do nothing. Second group, you only take the tumor out without addressing the lymph node. The third group, you take the tumor, lymph node out at the same time. The fourth group, you do the whole 9 yards, including the liver tumor. And every single step the surgeon did, patient do better. So in other words, the debulking concept to reduce the tumor burden is essential. So let me come back to where I'm going to address today, the midgut. So you heard most of patients come in with a delayed diagnosis. In my experience, 80 years average. The patient running around different hospital, different clinic, and they've been told they have menopausing, they are crazy, the electro bowel, you name it, all kinds of different differential diagnoses. Until the patient keep bitching about this, so the physician say, I'm going to get a CAT scan just to shut the patient's mouth up. So all of a sudden the CAT scan show a whole kind of holes in the liver. Say, holy moly, what are we dealing with? So at this time they do a biopsy, come back neuroendocrine tumor, and they tell you, slow benign disease, wait and see. Or it's too late because you're already in the liver, nothing we can do about it. All this are wrong. So now let me show you some example of fasten your seatbelt. There's a lot of slides coming. So you see that the intestine, one part of the intestine turned dusty because the blood supply got choked off by the lymph gland within the base of the vessel. And the liver mass is this big. As a matter of this patient was sent to the place I was trained at Washington University. My professor looked at CAT scan, tell the patient, said, no way this can be done. Somehow they find me on internet, or maybe Bob send them to me, and I operate on. Another patient, you can see the intestine almost ready to die, looks very dusty. And then you see how big the tumor in the liver. And then the next three slides are the same patient. You look at the liver, light up like July 4th firework. Guess what? Where it's coming from? From such a small tumor. So this is a very interesting phenomenon. Usually the cancer biology we call staging system. You can predict. If breast cancer 2 centimeters or less, the chance of lymph node metastasis is 7%. You go up, tumor getting bigger, the chance of lymph node metastasis increasing. When the lymph node involved, then you worry about the liver metastasis. It's like that, very predictable. Somewhere, somehow, the carcinoma is small enough to bypass all this regular biology. So the tumor biology in carcinoma is completely reversed. Like I said, the regular tumor, you primarily have to grow big enough to get the momentum to go lymph node. When the lymph node get big enough, you go to the liver. The carcinoma completely reversed. Remember the three slides I showed you? Very small primary in the small bowel, and you have a whole bunch of lymph node choking on the blood supply, and your liver, like July 4th firework. So in other words, any physician treated disease using normal common biology, treating other cancer, they're doomed to fail. And guess what? When they fail, they say, haha, sorry, you had a funny disease. That's a disease behavior. I say, absolutely not. Maybe we screw up. So let's face the fact. So what I do is, if you ask me what's the best way to treat the primary tumor, the lymph node, and treating the liver met, I'm going to focus on the primary tumor and lymph node. And the way I look at it, this disease is almost like addressing with the terrorist issues. A very small tumor, like Bin Laden, I show you our first few slides, so small I didn't use my finger to point out, and they set up the training camp. Those are training camp in Afghanistan somewhere. They're choking the blood supply, right? And all of a sudden, when they mature enough, they go to abroad, go to France, go to England, go to somewhere, and all the liver mets everywhere. So in other words, to treat this disease, the best thing to do is you find a special force, Navy SEAL like me, boots on the ground, knock out Bin Laden, take out lymph node, and then you can call Air Force, anyone else to help address the liver issue. So if you ask me what the three top choice treating this disease, especially lymph node in the primary, and I say first choice surgery, you say, okay, Dr. Wang, what's the second choice? I think surgery. He said, what is third choice? I still think surgery. Of course, now the question is how surgeons should do the operation right in the correct way. So this, I show you the patient, right? Very small tumor with a liver mass like July 4th firework. How are you going to address this thing? Traditionally, we've been taught you do 5 centimeters on upstream and 5 centimeters downstream, you will get all the tumor out. I said, ooh, who come up with this great idea? The tumor will march and you say, stop, 5 centimeters, cannot go further. And go down south, 5 centimeters, stop, you cannot move further. Who come up with a stupid idea to teach people like this? I said, maybe there's a better way we can scientifically to evaluate how the condition works. So I start to say, I'm going to rebel. I'm going to do something different. So we've been using blue dye to map out the cancer escape route for a long time, 25 years for breast cancer, melanoma. I say, maybe I can use this in this setting. So that's my beautiful hand. You can remember that. So I'm injecting blue dye around the tumor, and I can trace where the blue dye, the lymphatic channel can go, the tumor cell can be floating to, and I can see some of the lymph node I would otherwise miss. And the thing, you look at this patient, this is 18 centimeters still running. If I just stop at a 5 centimeter, I will have a 13 centimeter contaminated intestine with a potential tumor seeding in there, and I would miss. So this is just to show you, you can read the slide. This is another 21 centimeter tumor still running. So I come up with the idea, this is the funny thing going on. Why this is doing this? The funny thing, every time I inject the blue dye, I see 3 things come together. When I see a long tracking of the blue dye in the intestine running, they usually had a bulky lymph node. And when they had a bulky lymph node, I feel the intestine very carefully. I usually find more than 1 tumor. The highest number I find is 107 tumor in 50 centimeter of intestine. So I come up with the idea, maybe I can put all the 3 findings together. Maybe it's all unrelated, but maybe it just link I should have figured out. So what I figured out is this. When you have a tumor like that obstructing the lymphatic channel in the blood vessel area, so lymphatic is supposed to go home, driving home, back to the heart and recirculate. But the highway ramp got closed up by the tumor. So what do? You drive on the next street, right? You're looking for the next highway ramp, still closed, you keep going, right? until you keep find that the highway ramps open. You say, oh, thanks God, I'm on my way home now. So by doing this co-homing mechanism, you will see the blue dye go everywhere. But this is almost like bird shit phenomenon. The birds fly across your windshield and shit over your windshield, and all of a sudden, a whole bunch of bird shit in there on your window seat. It's exactly happened like this. When you have the blockage of lymphatic channel, your lymphatic try to go home, try to find a way home. They cannot find a way home. They keep driving on the road, and the bird shit start to drop. And that's how it happened. So if you look at all the textbooks, they tell you carcinoid or neuroendocrine tumors, 30% are multiple primaries and 30% were recurrent. That's all not, 30% was not multiple primary. Those are drop metastases. It's a big difference. So as a genetic study from Sweden just showed all those tumor from the same patient identical genetically. So that's from one same tumor primary, and they drop down. So the mapping is very important. So to me, if you use real mapping, you really can scientifically design the margin. You will get all the lymph gland contaminated out, and you don't have second guess. Also, you can do something very interesting. Like I just show you a few more tumors. See, there's one tumor I would miss if I didn't have a blue dye. So now, where I'm going to cut my intestine very easy. I can have my intern do this now because you can see the blue dye next to it. Can you guys see that, the green? So I don't have second guess. Say, where should I cut it? You see the blue dye? Yeah, I can have literally have my first year intern to do this with me without screwing up. You can see that very nicely. So the tumor come out. So the beauty about this technique, this patient someone sent to me already had a surgery. I had to redo surgery. And I said, I'm going to try the blue dye again. You see the hookup side, the previous hookup side, and the blue dye across it. So in other words, this technique can be used even someone already had previous surgery, and very nicely demonstrated. So the other thing I become rebelled is when we was resident, we were trained. Most of the tumor in the small bowel are toward the terminal ileum. So we was taught at Washington University, if you have terminal ileum disease, you do a right hemicolectomy, no question asked. And my professor will tell me, say, it's highway, it's my way or highway. You do it my way or I do it myself. So we had to take the right call and no question asked. And I started to rebel again and say, wait a second, the carcinoid patient already suffer from diarrhea, from the serotonin oversurge, on the medicine, suppressed pancreatic function. The quality of life is already very bad. If you take the ileocecal valve, you may make the quality of life even worse. Remember, the ileocecal valve is a God-made dam to slow down the traffic in the intestinal tract between the small intestine and the colon, to slow down so your small intestine have chance to absorb nutrient. If you take that dam off, now everything will go straight through. So some people, you do that, they can shit like horse. What the point? You save their life and their quality of life completely go down to the window, so it's just no point. So I started to say, who said we must do the right colon? I say, if I can use the blue dye to show the lymphatic channel did not cross the right colon, I'm going to say the ileocecal valve. So that's what I'm doing. So like this patient, the blue dye come to the right colon, I will take the right colon, like this patient. On the other hand, if the blue dye turn around, did not even contaminate the right colon, I save it, right? What's the point to take that uncontaminated, part out? So like this one, I save it. So this is an interesting slide. Look at the most important thing is the second line. This I presented about 4 years ago now. 35 patients, I had to redo surgery. Some of the I did, some of the patients are done by some other surgeon. When I went back, look at the bottom part, the third line, 19 of the 35 patients, when we operate on, we see the tumor right at where the previous surgery site was. So that's what I said, the 5 centimeter margin, the traditional way, we screw up without a blue dye. And you look at the bottom line, and the bottom second line, since we've been mapping, knock on the wood, we haven't seen any tumor recur in the small intestine yet. So apparently the common report is cancer kind of repair and recur, maybe it's a surgical error. So what I tell people, say, yes, do the surgery and always do mapping. You can do the right margin. You can save some of the idiocy cover. And then backwards, as many as 44% of patients, I can save their idiocy cover out. And those patients appreciate because the quality of life is so much better. So the next thing I get involved is, when I was a resident, I only saw 2 patients in my training with a neuroendocrine tumor. And all of a sudden, I got flooded with so many patients. I do maybe 2 cases, sometimes 3 cases a week. And I said, wow, do I have any reference I can look it up? I look at reference. I cannot find much reference at all. So I finally figured out maybe I should be able to start writing papers to be the reference for so people can learn from this, my experience. So 78% of patients sent to me has been seen by at least 3 surgeons in this country and been deemed unresectable. So your tumor is too advanced, wrapping around the vessel, too dangerous for us to even try. So the first 3 patients I bailed out. All 3 didn't do well, needless to say. So I say, I must push the envelope to give the best shot because otherwise I may not be able to help those people. So I try to rebuild. So this, you can see those lumps, those are lymph nodes in the mesentery. This is a chip shot. Everyone can do it. You clean up very nicely. Now, this patient has a 15 years disease. This is the base of the intestinal vessel right underneath the pancreas. The tumor is sticking out to my face. So what do? You look at the CAT scan. You see the tumor wrapping around the vessel. Okay. I just take my time. I chip things away, just take my time. I start to identify every single structure. And then by the time I'm done, maybe 8 hours, 10 hours later, just all the tumor come out nicely. This another one. This now I'm showing off now. You see the Bin Laden, very small Bin Laden. Remember I tell you, very small, that's Bin Laden. You need me to find it. You will not see on CAT scan, you will not see on endoscopy, you will not see on, capture endoscopy, nothing, unless boots on the ground. See how much tumor just Bin Laden created. Same patient, okay. Now you see another patient with a tumor wrapping around the vessel. I work my way through. You see the portal vein going in there. You can see the splenic vein on the side. You can see the aorta underneath. You see the SMA underneath. By the time I'm done, it's like someone take the gloves out of your hand. And that's how much tumor I take out on this patient. And this another patient from the referral center down south, Florida. Again, see I clean out nicely. It's just like almost like a new beach, someone laying there on the beach. There's another root of mesentery underneath the pancreas. The top part is pancreas, and you can see the vessel. Everything I'll clean out, and just how much lymph node I get out. So the other thing I rebuild and come up with a different idea is, after I spend 8 hours, and I say, wow, I can do very well on this tight debugging thing. I'm getting very, very comfortable with that. However, if I do a very difficult clean dissection like this, God forbid, there may be microscopic disease I left behind. If I don't have better way to address this, and this tumor come back, will defeat me, right? So I come up with another crazy idea. For a long while, all the patients come to my surgery room, I take the tumor out. I will send the tumor to the research lab. I grow the tumor out, and then I put the different chemotherapy into the living tumor cells in the lab to see which chemotherapy will kill the tumor cells. So I think that's the best way to pick out the chemotherapy agent, right? I have a true test. So very interesting. I find the first time I did a study, 69% of patients with a small bowel carcinoma will respond to 5-FU treatment. When I did repeat my studies, 93% will respond to that. So I come up with a crazy idea. I resect the tumor with a big hole in the body, right? Tumor will be removed. I said, can I fill up that defect, that hole, with some chemotherapy agent and let it sitting there? And maybe the chemotherapy will, based on this, microscopic living tumors, and they will die. So I started to do this. So you see the hole in this mesentery, and there's a absorbed material called gel foam. We use that to stop bleeding. Sometimes we put in there. I think this almost like sponge. You can soak in the chemotherapy agent before you put into it. So I started to do this and put into the cavity, and then I sewed that back and like making Chinese dumpling, and I call it Chinese dumpling. And works very well. So I present the first time in the Society of Surgical Oncology meeting in 2012. At that time, I have 32 patients. We had had a Chinese dumplings, 30 patients without dumpling as a control. And the 5-year survival, the first time I present that was the same. The two groups don't make any difference. The important thing is the 16% of the 16 of the 30 patients did not get dumpling. I have to reoperate for whatever reason. The 32 patients didn't get a dumpling. Only 6 I have to take them back to the operating room. So that's big difference. The one need to reoperate the 53% without the one need to reoperate only 18%. The more striking thing is the next line. When I go back, the 19 patient I have to go back in the patient with did not get the Chinese dumpling. 9 of the 16 I find tumors. On the 6th patient get the Chinese dumpling, I take them back to the operating room. I only find 2 patients with the tumor left in the where I was moving around. So in an hour, I dropped the tumor recurrent, the tumor resection back from 30% to 6.25%. Yes, one of the commentary people look, I say, Dr. Wang, that's impressive, but don't mean shit to me. I said, excuse me, what do you mean don't mean shit to you? He said, your line said very clear, the 5-year survival is no difference. And we are cancer surgeons. We will only look at survival. If you cannot increase survival, then you're not doing anything to me. I said, that's a really short-sighted, because if the patient has a less chance of recurrent disease, less anxiety, better quality of life, less pain, less suffering, less chance to get reoperation, I see all those are benefit. You cannot just, disregard like that. But anyway, so I went back, I tell my residents, we need to do a long-term study to see when the Chinese dumpling do some good to people. We presented in 2014 in the Surgical Society Oncology meeting, we got the presentation. Now you look at now, the median survival difference is 88 months. So with dumpling and without dumpling. So I almost want to tell them, say, go home, eat my shit. Now the other thing I rebelled is, for a while, we are cancer surgeons. So when we do a liver resection, we always say you must to get a clear margin. You do anatomic resection so you don't have tumor left behind. I did one case and regretfully I did it. And then I went home and think about it, I said, what I'm thinking. This disease with the reverse pyramid, there's so many diseases somewhere, you just cannot see it yet. Why you're kidding yourself to do a formal resection to take so much healthy liver out, just try to quote unquote get a clear margin? Because that's not a way to think. And you need to reserve the good thing for the rainy days. So I start to do a liver resection for carcinoid patient or neuroendocrine patient, do only tumor debulking surgery. I don't sacrifice any healthy liver. So they can always go for the PRRT, they can go to chemoembolization, radioembolization, afinitor, any other drugs to deal with this microscopic disease. So let me show you a couple of examples. This patient is a lawyer. His wife's a lawyer, and no one dare to touch them, not because they're lawyers, because of the disease process. You see how big the tumor is. It's unbelievable. And with a tumor wrapping around the vessel in the mesentery. So of course, they got turned down by big name hospitals, 5 of them. Finally, they find me, come down, they look at me, say, what do you think? I say, you must learn something from me. And the wife looks at it, everyone says, you're crazy, you're nuts on internet. But you are to the good way of kind of nuts because you give everyone a chance, you will take on. So I say, yes, I will take on. Even both you and your husband and your wife, the lawyer, I will take on. So this, how much tumor I get out in the liver. I did not sacrifice any healthy liver at all. Now, I just show you the biggest tumor and only the tumor take out. There's a gentleman from San Diego area and went to 3 different hospitals, big name hospital in San Francisco area and the UCLA, all that. No one want to touch him. Again, he find me on internet, come down here with a tumor like this and go into the vessel. So everyone turned him down. He find me, he's like, what do you think? I say, I cannot promise anything, but I can promise one thing, I'm going to try my best, give it a shot. When I can get it done, I'm not sure. We'll only find out tomorrow. So we did it. It's come on nicely. Nothing else. I did not even transfuse him. So the other thing I do is, after I digging around the vessel, sometimes the vessel get beat up, they bruise up. So the intestine looks very, very unhappy. Looks like blood supply is compromised. In old days, what you do is you leave the abdomen open. You just temporarily close it with a sponge. You put them in ICU, warm them up, then you go back to the operating room the next day or third day or fourth day. We call it second look operation. And I did 1 or 2 like that. Patient was extremely upset. And they wake up with see the black sponge on their abdomen and say, what shit did I like that you put there? I said, sorry, I did not finish surgery because some blood vessel in the intestine looked funny. I had to go back in there again. They are very upset. So I think maybe I can do something different. So what I decided to hook up together anyway. But like this patient, the intestine, after I digging around, didn't look too healthy. So I put back together. I put a drain there where the hook side is. My thought was, if the hookup side start having problem, then the intestinal content go leaking out to the drain tube. I will find it out. So I will not let the patient turn too sick before I find out something go wrong. I can go back to the operating room right away. However, if they're doing fine without any problem, a few days later, I can go back to the operating and cut the tube in half. And I can use the remaining tube go into the abdomen as air blower. I can blow air into the abdomen. And I can blow that abdomen look tented up like Goodyear balloon. Then I take the tube out, use the tube track, I put a small camera in there. And I can look inside, say, did I screw up or not? And you know, this is why I do this. 5 minutes, I can get done, and patient wake up, never have anything else. So this is called laparoscopy second look, and I'm the first one did it, and I have 12 patients so far did this, and everyone's very happy. So now the other thing I kind of come up with a different idea is, when I see so many patients come to my clinic, they all show me their CAT scan, their everything, pathology, and they always hand me a trial scan. My simple mind is, gee, if everyone already get a trial scan, if the nuclear medicine's big, stupid camera in the radiology suite can pick out a tumor, I should be able to use a handheld Geiger counter in the operating room, pick out tumor precisely, right? I'm so much closer. So I start to do it. My partner tell me, don't waste your time. European people tried that already, failed already. There's many 10 report at least say that don't work. I say maybe it's a user error. It's not a technique error. Maybe they're just doing it right. So I just say I'm going to do it. So what I did, I had patients come and get a triotide injection, come in at different time. I operate on them and see which one works, which one does not work. Turned out if you have a triotide injection 6 days before surgery, it's a perfect timing to go in there to do the surgery. But anyway, how I started this is a lady from Washington, D.C. area. She looks 70, 80 years old, looked like pregnant woman with all the tumor there. I took all this out. She come back for a checkup. Everything all negative, but those 2 things, one up in the upper chest and the neck. And she was very upset. She said, Dr. Wang, I want to do something about it. And I said, I never know how to address this issue because no one reported what you should do for this. So I looked reference, I cannot find anywhere. So I tell him, say, I think you can just wait and sit on that. And she looked at me and said, didn't you tell me don't sit on the live cigarette butts? I said, oh boy, I'm eating my own words now. I have to do something. So I say, okay, I'll do something for you. So I take her back. I cover her face up so she don't charge me for fees. So I make a 3 centimeter incision. I use the Geiger counter into the area and the Geiger counter tell me, say, yeah, you find something hot. So I just very carefully dissect around, tumor come out. So again, it's a measuring thing on top. Outside of the patient, I double check to make sure I got the real McCoy, not the decoy, and it was good. Just another patient. Now again, this lymph node up the mediastinum area, 24 lymph nodes in this specimen, all positive. And this just show off slide again. Patient will do very well. You go home the next morning. This is a patient with a pancreatic neuroendocrine tumor with a lymph node wedging between the aorta and cava, a whole bunch of it. And tumor this big, you don't need me. Ray Charles can find it. You know, you say, oh, God, man, how could anyone miss tumor this big, right? Ray Charles can do it. You don't need Wang for this. The funny thing about this story is the machine kept beeping, the Geiger counter kept beeping and tell me I missed something. And that is that the kidney on the other side, the vessel go to the kidney called renal vein. And something kept beeping in that area. So I have my resident use a sucker to push the renal vein down and I find the tumor behind it. Otherwise, I would never find this tumor. So this technology is very good. The next question people come to ask me all the time, say, I had a neuroendocrine tumor, unknown primary. What should I do? Endoscopy, colonoscopy, capsule endoscopy, arterial scan, whatever. I say, no, you don't need to localize a tumor. You need to localize a good surgeon, to find a good surgeon, and they find it. And I just published a paper not too long time ago. We have a 30-some patient with unknown primary. Every single one, we go into operating room, we find the primary tumor. So this is the 5-10 years survival for my group before I leave them. So you see the 5-year survival, 10-year survival is almost double the national database. So we must be doing something okay. Now I'm going to close out my remark pretty soon. This is a lady, very interesting story. She had an MEN1 disease, 40-some years old. Finally, she's been in the single circle for some time, and finally met someone and get married. And they try to conceive and cannot conceive. So the fertility doctor finally tell her, say, why don't you get a CAT scan to see what's going on? And this was a CAT scan show. You just see the tumor in the pancreas. It's bigger than the kidney on the both side, right? So the husband tells her, don't worry about it, honey, we can handle this. So they went to Rochester and Minnesota. They did a very fancy test, yeah, CT angiogram. They look at it, how the tumor is and around to the vessel. And you can see it's very complicated. So they told her, say, sorry, we cannot do it. They have a surgical team line up. They say, we cannot do this. And also they warn her, say, don't let anyone try it. If someone tried this, you may bleed to death on the table. So she was devastated. She called my nurse and crying, sobbing on the way home. And important said, did you talk to Dr. Wang yet? And she said, so what? You know, I already done the Mayo Clinic, so what Wang going to say? And important said, you never know. Wang is crazy. He may take on you. Don't count him out. Just talk to him. So all of a sudden my phone rings. And Porter asked me, Dr. Wang, so-and-so want to talk to you. Can you talk to her? I say, what's the story? So she told me. I said, yes, patch over. I talked to her. So I talked to the same old famous line I had. I say, I cannot promise anything, but I can promise you I will take a good look at you. If it's possible, I will do my best. Whether the tumor will be removed, I don't know. It's in God's hand. So she come back. I did the operation on her. That was done in 2009. And she been to follow up with me every year. She come back and said, I cannot try to get pregnant yet. I said, no, have fun for another year. Because I just don't know when the tumor will come back. You know, I said, just have fun for another year. And maybe next year you can try to get pregnant. But just 7 years now, she's still around. So this is really the last one. I'm going to finish up the story and then we call it quit. This is a patient got surgery done somewhere else. And decided to come to see me with a stack of scan and everything, come to and drop on my desk, say, Dr. Wang, you need help me. I said, what's the story? He said, I just had a surgery But I think my surgeon screwed up something, missed something. I said, no, don't jump in the conclusion yet. Let me go through your file. And so I read the file. And I told him, say, no, your surgeon is a very good one. Everything detailed, like map. Every single step, your surgeon will put down what he did and what he found, why he do so. I said, there's no way your surgeon missed something. He said, no, I read, no, he missed something. I said, what's the story then? Why you think so? He said, I'm no longer having sex with my wife. I said, whoa, buddy, you're the wrong clinic. I'm not a marriage counselor. I'm not a psychiatrist. I'm not a psychotherapist. I said, you're the wrong clinic. And he just looked at me. Everyone said in the internet chat room, say, you are the best. You can figure out. You can help me. I said, but I have nothing to help you because the surgeon did a very good job there. And so my medical student looked at me. Remember, we teach medical students that you must take the patient's word seriously. When the patient tells you something, you have to listen. So I find it maybe say I should at least ask another 2 questions before I send him out. So I asked him, say, oh, can I ask you why you are no longer having sex with your wife? And he said, it hurt like hell when it comes. I said, whoa, stop. I'm not a urologist. The painful ejaculation, I have no idea how to address, how to treat it. I said, you need to see a urologist. He said, no, I want you to take care of it. So finally, what I did is I said, at least I get a nuclear medicine colleague to get a chair scan. And if I was hoping that chair scan would be negative so I can push him out the door and say, haha, I told you. Unfortunately, that chair scan come back positive. At the lower part of the abdomen. So I tell him, I had to apologize to him. I said, I'm sorry, I was wrong. You are right. There's something there. And he said, what, are you going to do something for me? And I said, yes, I will. So we go back to the operating room and open up the abdomen. Spend 2 hours and a half. I cannot find nothing. Zip. So I said, God damn it. So that chair scan was false positive, not tricked me. Now I'm in the area. So I used the carrier counter to keep finding it, but the carrier counter kept beeping. And all of a sudden, light bulb in my head went up. I said, oh my God, I just read a report the night before. There's a case of testicular carcinoma been reported by the Swedish group. I said, holy moly, I get the second case here in my hand. Must be in the testicle. So I close the abdomen. I do a groin incision, like I try to fix hernia. That's how you do it, the testicular tumor operation. So I did that. And I don't know if you guys can recognize the anatomy. That's my finger. That white tube thing is very different where the sperm go through. And you see the lump with the tumor. And here, 3 tumors wrapping around the vast difference. That's why he's having pain when it comes. Ladies and gentlemen, I've done enough post-ups, check. This is the best one I've ever done in my life. You can see he smiles 3 miles away. He basically landed in the airport. I always saw that. And he walked into my clinic and he says, thank you. And he hugged me, almost truncate me. And if you ask him, does he believe in God? And he said, yes, sir, I do. And he's a Chinese. I'm going to stop here.